RSV can clearly be considered an area of unmet need. So this is somewhat like influenza in infection that can be considered opportunistic in nature. Amongst pediatric population by the age of 2, all kids will have had at least one RSV infection, worldwide leading to over 3 million hospitalizations and 200,000 deaths. And sadly, 99% of those deaths occurring in low and middle income countries. So I think right off the bat, if we're recognizing what challenges exist, I think you could even suggest that access or perhaps level of care could be a primary difficulty in number one, figuring out how to treat these in clinic, and number two, deploying any drugs that successfully make it to market. I think some of its opportunistic behavior can be described in these compromised populations. So children less than 1 year old who are born preterm were 9-fold more likely to die by respiratory complications relative to influenza. So this is a serious virus, particularly in those compromised populations. The symptoms and I think the diagnosis is a bit difficult in the sense that if you have a healthy adult per se, symptoms will often be similar to a cold, but again, in compromised patients, and we can see here elderly with cardiopulmonary disease or those who are immunocompromised, can have very serious complications with lower respiratory tract infection rates, which are abnormally high, and mortality rates to match. So currently there's no effective treatments for RSV, and I think I'll show you some of what's under development. So speaking specifically to some of the development challenges, there's no guidance currently available for developing either treatment or prophylactic treatments for RSV. And really to that end, you're talking there needs to be an agreement on both the disease severity, and that's really speaking to identifying what patient populations are going to benefit from treatment. So that's going to be an important factor, and much like what was just mentioned, clinical endpoints are going to be important. Like influenza, as just mentioned, virologic endpoints aren't going to be sufficient, and really clinical endpoints are going to have to be an important factor in successfully demonstrating efficacy. And as just mentioned, the last point, endpoints are also going to have to acknowledge the different levels of healthcare. If we talk about that first statistic on the last slide, if even supportive care can make a difference, that needs to be recognized and dealt with, both in development and recognizing who might benefit from treatment. So here's a cartoon of the RSV viral life cycle. There's two targets where drugs are currently being developed, polymerase inhibitors, as is common for antivirals, and I'll be describing some of the attributes of a fusion inhibitor that we're working on, prosatavir. So prosatavir is a F-glycoprotein fusion inhibitor, so there's two glycoproteins that are important in the fusion of the viral particles to the host cells. This F protein is conserved across the viral subtypes and therefore should confer greater antiviral activity. This is the compound's demonstrated efficacy in non-clinical models, and a nice attribute is that it concentrates well in lung tissue and lung epithelial lining fluid relative to plasma. As we describe some of its characteristics, preclinical DDI characteristics suggest this compound's transporter, substrate, efflux and uptake, as well as substrate for CYP3A, and a weak inhibitor of efflux and uptake transporters in MATE. And moving along to the clinical program, currently we have data from 7 phase 1 studies in healthy subjects. I'll describe in pretty good detail this phase 2A challenge study where we inoculated individuals with RSV and had some good data coming out of that. But the real challenge, which again I think was stated well by Dr. Kikuta, is in phase 2B trials and phase 3, the challenge is going to be identifying and implementing these successfully. So even if we demonstrate a successful proof of concept under well-controlled conditions, demonstrating that in real life has its own challenges. We can talk about that later, or not if we don't have time. So this is the single-dose escalation in healthy subjects. So this drug was dosed up to 800 milligrams, showed approximately dose-proportional increases in exposure and a nice long half-life, 33 to 35 hours. With respect to its clinical drug interaction profile, There was little impact of cyclosporin on the PK of prozadovir, more so an impact by COBE suggesting that CYP3A rather than drug transport is important in the disposition of the compound. I recognize I should have made an update to the slide with rifampin and efavirenz as inducers, both of which dropped the exposure of this compound. I think are mischaracterized based on Dr. Kirby's talk yesterday, perhaps on the transport side. Here's what I wanted to get to and where I think some of the interesting data is. So this is the phase 2A study where we inoculated subjects with RSV for those who tested positive after 2 days, received treatment with various different regimens. First with this 50 milligrams, then followed by 25 milligram once daily regimen. That with the goal of having a fourfold margin over the protein-adjusted EC95 of the virus observed. It was the M37B strain, which is considered wild type and commonly observed clinically. Interestingly, we also looked at the behavior of a single 100 milligram dose as well as some lower doses that may or may not have been effective. So the results of this study are already published, the journal citations up in the top corner if you have interest in it. Here's the results summary of that, though. So there's a clear benefit, and actually approximately a greater than 3 log impact of this fusion inhibitor following this administration relative to placebo, with corresponding benefits in nasal mucus production and respiratory symptoms as measured by spirometry. So in a controlled setting, I think what we're trying to demonstrate is can this drug be effective? The next challenge, I think, is getting to these next steps. Can we identify some of these people fast enough, get them in treatment, and then we can talk about some of their attributes. So looking at the behavior of the different regimens that they received, you can see decent behavior by all, including this single dose of 100 milligrams prozadovir. You see a significant antiviral effect over the time course evaluated, and with similar findings with regard to its clinical symptoms. So we used data from this study and really, prior to initiating some of the phase 2 studies, have a better understanding of the dynamics between viral load, clinical symptoms, and dose of prozadovir. So we modeled various scenarios, and I'll show you those in a moment, really looking at the dose and time relative to inoculation and try to assess the importance of that. So here we're looking at prozadovir effect as a function of dose. In these middle rows, what we're looking at is viral load, and clinical symptoms as a function of time with modeled doses from 2 to 200 milligrams. And again, this was based on that proof of concept data. And what this showed us was doses greater than 50 milligrams confer maximal antiviral effect and corresponding improvements in clinical symptoms. I think more interestingly was the effect of the drug when we looked as a function of time. So in these modelings, we applied a theoretical regimen of 200 milligrams followed by 100 milligrams once daily, with the variable being time post-inoculation. So we were waiting longer and longer periods before applying the drug to the viral kinetics. And really what we learned is that if you don't initiate treatment within 72 hours, let's say, there's limited benefit. And that's something that could be specific to this healthy population. So recognize that healthier individuals have a shorter disease course when infected. There's data out there suggesting in the pediatric population as well as immunocompromised population, the viral shedding continues for a much greater time period. So I think that's a question that needs to be answered in later phase 2 studies and phase 3 studies, i.e., is this window broader for those patients or perhaps not? And even looking at this data, I think you can understand some of the complexity in demonstrating efficacy for these compounds. Number one, we need if the subjects start to develop symptoms, how soon do they seek health care? Once they seek health care, are they receiving the proper diagnosis? And subsequently, and could they get enrolled into a study, et cetera? So you can see, much like influenza, why I think drugs of this nature will likely be developed prophylactically as well as for treatment. I think some of this modeling, I maybe to spare time, I'll skip some of this. I think this some of this modeling suggests some of those prophylactic treatments or early treatment schemes could be possible. So the drug, which has a longer half-life, if you're able to administer the drug by some time to figure out what's really happening, safety, of course, provided, you could allow situations like that. So perhaps enabling schemes in high-risk subjects. Phase 2B studies are currently ongoing, and I won't go through these, but ultimately we're looking at currently the effect of this drug in hospital, basically more healthy but hospitalized subjects with RSV, and those individuals are receiving a single dose, looking at both viral and clinical endpoints, as well as looking at immunocompromised populations, so hematopoietic cell transplantations, and those at significant risk with lung transplantation. Data from all these studies are going to be forthcoming, so we won't comment on those for now. And in conclusion, I think I demonstrated, or hopefully learned some of the attributes of the virus, some of the attributes of the drug, and really I think the session and the concept that you guys were trying to get after with this session was neat, because some of these other viruses that are currently being investigated, I think there are some very unique challenges relative to these chronic infections, and really it's going to be the efficiency, effectiveness of healthcare, communication amongst providers, communication between companies, regulators, and really better understanding how we can deploy these to demonstrate efficacy. If we can demonstrate that, perhaps that creates the model by which we can use these drugs more successfully if the time comes to market. So that's all I have. Thank you.
Great.